Uh, Thank you very much, sir. And this is another very important topic we'll be discussing today. It's a, it's a heart failure symposium, and this is basically related to heart failure as such. And we have none other than Dr. Anant Nigam. Uh, if I keep on giving his introduction, it will take another 20 minutes. So I'll be very brief in talking about him. I know him for more than 40 years now, and he was the first recognized diabetologist in Rajasthan. And when we were young practitioners, we used to refer him all the patients of diabetes, and he gave us the best of treatment at that time. He is director Nigam Diabetes Center, Jaipur. He is experience of more than 38 years. He is a fellow of Royal College of Physicians, Glasgow. Delivered invite lectures at IDF 2011 and the Johns Hopkins University School of Medicine, USA in 1997. There's a long list of awards, and he's been awarded several orations, including RSSDI 2010, NDSO, Professor N. Bhu Oration, etc., etc., plenty of them. Founding member of World Foundation for the Prevention of Diabetes, Atlanta. So this is the briefest I could make of his introduction. And I hand over the mic to none other than Dr. Anant Nigam to take the further proceedings of the program.
Thank you, Dr. Meenawat, for this kind invitation and also the kind introduction. Let me begin by saying that I think your forum is doing a great service by providing knowledge as a whole to physicians and not to a particular specialty. Let me thank you for inviting me to speak and moderate this session this morning on heart failure. People would wonder, why is a diabetologist sitting there and trying to speak on heart failure? Let me remind my friends that diabetes is a multidisciplinary problem with complex issues addressing so many other areas that you see. We all know that type 2 diabetes is a cardiovascular equivalent. Amongst the various complications that you see in diabetes, the cardiovascular complications, heart failure is something that is not too well understood and not too well recognized. Of course, the recent trials have really put all the attention on heart failure. But also remember that heart failure is a preventable and treatable complication. It's a debilitating complication, and it gets you significant morbidity and mortality. Please remember that diabetes is not an innocent bystander, but a very important driver of heart failure. These are my disclosures. I work and speak with almost all the big companies. We all know, as I mentioned, that the cardiovascular disease and diabetes are intricately linked. And if you see the panel on your right, it very clearly shows you that somebody who did not have diabetes and had a myocardial infarction had about 18% risk of a 7-year incidence of myocardial infarction. But look at the guy in the blue who has diabetes but did not have MI, has the same risk. So just being diabetic gets you that increased enhanced cardiovascular risk. Unfortunately, these macrovascular complications start way before you are clinically diagnosed as diabetes. 65% deaths are due to cardiovascular disease. 75% of all hospital admissions are because of diabetes. And you have this increased risk of coronary artery disease, stroke. But look at the increase of heart failure. It's almost 2 to 5% more as compared to other complications. And it may be the first manifestation of all the other cardiovascular risks and complications that you are seeing. And it is said that it is frequent, it's forgotten, and fatal. So can we just link up the two? And what can we do further? And this very clearly also shows you that amongst the causes of hospitalization for heart failure and diabetes, it stands out amongst all the other complications, whether it's stroke, dyslipidemia, or acute coronary syndrome. So HHF, both in men and women, really dominates the complications that you see in diabetes. Now, what is this heart failure? I know there are cardiologists on the panel who would probably define it better than me, but this is the American College of Cardiology saying that it results from functional or structural impairment of ventricular filling or ejection of blood. Very simple, and we've all learned that in medicine, in physiology. And all of you here know the cardinal symptoms of heart failure, which include dyspnea, fluid retention, and approximately 50% of people with diabetes develop heart failure. And this is the general classification recognized today, with reduced ejection fraction, which is called as HFrEF, is less than 40 ejection fraction, HFpEF, which is more than 50, and then you've got this borderline and improved and so on. But diabetics would probably have both of them. And this is the real cause of worry. Heart failure is a progressive condition with high mortality. That's the issue. And you can see it decreases your quality of life and increases mortality as disease progresses. The mortality remains very high in people with diabetes, 75% of all hospitalizations, tenfold high coexistence impact in the first year. If you have diabetes, look at the impact in the first year, 7% increase in 27% increase in risk of death and other complications. Now, what's this link between diabetes and heart failure that we need to really understand? It's an independent risk factor for heart failure, and Framingham studies have shown that this is an independent risk factor of heart failure. The coexistence really impacts how the disease is going to progress clinically and also the prognosis. It is prevalent in people with diabetes, 25% in chronic heart failure, 40% in acute heart failure, and the prevalence is higher than general population, almost 4 times. And you will find there is a gender disparity there, with women getting more heart failure than men. And so we've got to be very careful. The Mayo Clinic study published just in 2020 showed that 20% of these participants with diabetes develop heart failure independent of other causes. If you have structure, if you have a coronary artery disease, if you have other forms of heart disease, it is independent. So heart failure by itself is an issue that demands attention. And a data published in Circulation in 2019 said that they occur often concomitantly, and the disease independently increases the risk of the other. So if you have one, you're increasing the risk of the other. If you have a heart failure cohort, the prevalence of diabetes there would be about 10 to 45%. And if you have people with diabetes, the prevalence of heart failure is increased by almost 9 to 20%. So you have to remember that these two trends are occurring together. And I showed you that it is almost 2 to 5-fold increased in people with diabetes. You've got to detect it early. That is extremely important, because sometimes it may remain asymptomatic. Sometimes the symptoms are so indiscriminate that you won't even recognize them. So early diagnosis is important to prevent the progression of this debilitating disease. But unfortunately, about 50% of these people remain undiagnosed and untreated. But as I mentioned in my opening remarks, if you treat them early, it is preventable. If you recognize early, you will treat them early. Now, this shows you the risk factors of hypertension and diabetes. And if you look at the middle panel there, these are common risk factors which are common to both: age, sex, race, hypertension, obesity, coronary artery disease, and renal disease. And all of us know from clinical practice that if you have coronary artery disease, if you have renal disease, you're increasing the risk of heart failure. But look at the pathogenesis of type 2 diabetes with its antecedent complications there, and heart failure alone there with myocardial toxicity and other features there, the risk is multiplying and sets up a vicious cycle where the risk of heart failure continues to increase. On the left, you see are risk factors of incident heart failure among people with diabetes. And this increases with age. If you're older, your chances higher. With existing coronary artery disease, peripheral artery disease, nephropathy, retinopathy, long duration of diabetes, obesity, and if you have a high NT-proBNP on examination. The pathogenetic mechanisms leading to heart failure in diabetes are either going the ischemic way or the non-ischemic way. So if you have hyperglycemia, insulin resistance, hyperinsulinemia, you're probably heading for coronary artery disease through inflammation, endothelial dysfunction, dyslipidemia, and this leads to ischemic cardiomyopathy. But the other way, you could have cardiomyocyte hypertrophy, RAS activation leading to fibrosis, development of advanced glycation end products, and all this leads to diabetic cardiomyopathy and heart failure in diabetes. And therefore, people with diabetes could have both atherosclerotic and atherosclerotic independent mechanisms which lead to heart failure. What's the impact of dysglycemia on heart failure? You have a 30 to 50% increased risk of CV death. The dark yellow bars show you people with known diabetes, and this is pre-diabetes. So even when you are a pre-diabetic, your risk of cardiovascular death risk increases. If you have heart failure, then you've got dysglycemia here, 50 to 90% adjustment-related clinical events, and this is quality of life. So all this dysglycemia, this is the impact on heart failure. How do you control glycemia if somebody's got heart failure? Would you want the HbA1c which is 9, or would you want something that is about 6? And data is now very clearly shown that if you're around 6 to 7, so it's a U-shaped curve, and the best results are somewhere if you're trying to keep 7 to 8. And as we remember, individualization algorithms, which are described so well by the American Diabetes Association, etc. So somebody who's got a pre-existing cardiovascular disease, don't be too aggressive with glycemic control. But that doesn't mean that you leave your HbA1c around 9, and it doesn't mean that you try and get that low. So the ideal would be somewhere between 7 and 8. It is also estimated that for every 1% increase in HbA1c, the risk of heart failure would go up from 8 to 30%. So you've got to be careful that HbA1c management is also extremely important. Now let's talk about this patient who's a 65-year-old retired bank officer, got diabetes about 9 years ago, diagnosed with heart failure 3 years ago. His current medication includes an ARB, 80 milligrams. He's got metoprolol on board and spironolactone. This is the treatment that his physician had prescribed when I first saw him, along with his anti-hyperglycemic medication. But at that point of time, he was still short of breath on mild to moderate exertion. For 2 weeks, swelling on feet, 2 weeks, had been hospitalized twice in the last 6 months, and complained of fatigue. Now, when we did his evaluation, he had a BMI of 63, his pulse rate was fine, blood pressure was quite okay, pulse was 98. He had rals, but no V's, and had peripheral pulses, which were good, but had edema on feet. His HbA1c was 7.9, not too bad. eGFR was 70, but his NT-proBNP was 1642. Hemoglobin was 12.3. There was no fresh ischemia, and the echocardiogram showed left ventricular ejection fraction of just 24. So the diagnosis is very clear. He's got type 2 diabetes, he's got heart failure, he's got hypertension, and diabetic kidney disease, early diabetic kidney. But this current therapy is not really giving a symptomatic benefit to this gentleman. So how can we use these markers that I've tried to show with these arrows to really help understand and improve the management of this patient? Let's talk about NT-proBNP. Now, this is very closely linked with all these issues, and it has been shown that if you have a value over 1300, you have almost a 30% increase in the risk of heart failure in people with type 2 diabetes. You have almost 3.5 times increase in the risk of CV death and hospitalization for heart failure in people with diabetes and HFrEF. And it's also a 3.5 times increase in the risk of all-cause mortality in people with diabetes and HFrEF. And the pattern on the right shows you that if you give him a combination of sacubitril and valsartan as opposed to enalapril, you can see the decrease in the NT-proBNP. As diabetologists, and I think also as cardiologists, we need to really know what should be the choice of anti-hyperglycemic therapies in these people with diabetes and heart failure. Well, I'm just going to speak to you about the SGLT2 inhibitors, which is so well understood now as something that decreases the risk of hospitalization for heart failure, CV death, CV mortality, and what have you, everything there. So, and this meta-analysis here also shows you that both empagliflozin and canagliflozin, of course, this is published a little earlier, but also dapagliflozin decreases the risk of hospitalization for heart failure. The GLP-1 molecules are neutral, and the gliptins, except for saxagliptin, have been found to be neutral as far as heart failure. They don't increase the risk of heart failure. Of course, you've got to be careful in using GLP-1s in recent hospitalization for heart failure. The DPP-4s, as I mentioned, are neutral, but beware of using glitazones in people with long-standing coronary artery disease, people who are elderly. I think it's already out. Glitazones are no more used in those situations because you might just precipitate heart failure. Metformin is recommended. That's something to understand. Don't stop metformin if your eGFR is less than 30. In fact, new data shows that you may benefit these people. If your eGFR is more than 30, continue to use metformin, keeping an eye on eGFR. Now, what's the endocrinologist's perspective when you're trying to manage heart failure in people with diabetes? Now, most HFrEF patients are treated with conventional therapies, and you've been using, and we've all been using ACE inhibitors and ARBs, supposed to be the gold standard about 5 or 6 years back, with beta blockers and diuretics. But now you've got recent trials with neprilysin blockers, SGLT2 inhibitors, and the mineral receptor antagonists have shown far more superiority than you had with the conventional trials. And so what I've done is I've labeled them as disease-modifying agents. Like you've got the disease-modifying agents in rheumatoid arthritis and other conditions, here these are disease-modifying agents. So ARNI, angiotensin neprilysin blocker, the SGLT2 inhibitors, the beta blockers, and the MRAs, when combined, are probably the foundation of type 2 diabetes and heart failure therapy. And remember that you have to have almost all 4 of them on board, and they modify the disease. And how do they do that? Well, here it is. The mechanism of action of the neprilysin receptor blocker is once you inhibit this, it causes vasorelaxation, natriuresis, diuresis. And this is in fact changing the cardiac structure. It decreases fibrosis, decreases cardiomyocyte hypertrophy, and changes and makes structural changes in the heart. And similarly, once you block the RAS by using valsartan there, you're of course causing again similar things like vasodilatation and also improving structural damage to the heart. And now you've got the well understood mechanism of action of the SGLT2 inhibitors, which increase natriuresis, diuresis, glycosuria, and decrease the TG intraglomerular pressure and decrease cardiac preload, and also decrease cardiac afterload by improving endothelial dysfunction, improving endothelial function, decreasing vascular resistance, and all of them by changes in the myocardial energetics. Increasing oxygen supply, decreasing oxidative stress, decreasing fibrosis, they're able to also, like the RNA, able to improve structural damage to the heart. And that's why I've said these are disease modifying agents. Therefore, these are now supposed to be the 4 pillars of heart failure treatment. And it's so important to initiate these on time. You've got to optimize on time, and you've got to reassess. And these have to be on board as per new guidelines in about 4 to 6 weeks, with gradual up titration of these doses to get the maximum benefit. And so both initiation and optimization of these 4 pillars is extremely important. A question that may come to your mind is, if I have a person with type 2 diabetes, should I use both? Of course, the guidelines recommend that you use all 4 of them. But if you were to combine RD and SGLT2, I've already shown you the benefits that it gets you in the structural damage that heart failure does to the myocardium. But here you've got benefits, almost 62% reduction in CV death and HHF, 50% reduction in CV death, hospital admission, and all-cause mortality. All are decreased if you're using both together compared to conventional therapies in heart failure. Now, how do this benefit? How does sacubitril/valsartan help people in diabetes? Of course, we talked about the role of diabetes in heart failure and why are they interlinked, but we should then also know how these new therapies help people who got diabetes. Is it damaging for our glycemic control, or is it helping? And here you've got multiple benefits of sacubitril/valsartan. We showed you it blocks the AT1 receptor. It increases natriuretic peptides, and these are all increasing insulin sensitivity, increasing insulin metabolism, adiponectin release, and also increasing postprandial lipid oxidation. It increases bradykinin, which again increases insulin sensitivity. To our benefit, increases GLP-1, which is the foundation of all these incretin-based therapies, and decreases DPP-4 activities, which is already elevated in people with type 2 diabetes. So thereby improving probably beta cell function. So it improves insulin sensitivity, lipid metabolism, and oxidation. And on your right, you see the decrease in HbA1c of about 0.14% with ARNI as compared to enalapril, and about a 30% decrease in the new users of insulin. So because it increases insulin sensitivity, and all of you will remember when ACE inhibitors came in, you found that it increased insulin sensitivity and sometimes the doses of drugs, not markedly, but were sometimes changed when you're using very mild doses. And therefore, you've got now agents also improving insulin sensitivity. Let's come back to that patient before I wind up. So what are your options in this patient? Add a ARNI and stop telmisartan, add a SGLT2 inhibitor, increase MRA as required, continue metoprolol, or all of the above. And probably the correct answer will be number 5. So friends, what I've tried to show you here is that diabetes and heart failure are intricately linked. One could aggravate the risk for the other. I've also enumerated a number of pathogenetic mechanisms and risk factors for the occurrence of both diabetes and heart failure. It leads to multiple complications, which include hospitalization for heart failure and CV death. New data shows you that use of sacubitril/valsartan through its different mechanisms, and as I mentioned, these are disease-modifying agents, could really help change the structural abnormalities which start occurring with heart failure. And similarly, the new age SGLT2 inhibitors also provide benefits, both in cardiovascular and renal benefits that one could really hope for in people with and without diabetes. Now, SGLT2 also have entered the field of without diabetes, as well as new data shows that they may help people with HFpEF. And therefore, also remember that the combination of both RD and SGLT2 inhibitors and the use of beta blockers in MRAs will really lay the foundation for treatment of type 2 diabetes and heart failure. The most important thing that I would like to emphasize here is that time is really what matters. Thank you very much for your attention.